Friday afternoon in Texas. Okay, well, it's 2 minutes after. We should get going in respect of everyone's time. Good afternoon, everyone. My name is Bill Cole. I'm a professor at the University of Texas School of Public Health campus in Austin, and I'm a member of the Michael and Susan Dell Center for Healthy Living. Welcome today to our second of 10, count them, 10 summer webinars focusing on a sector-based approach to physical activity promotion. We are in the process right now in revising a state plan for physical activity as a public health priority in Texas. We have one that's a little out of date. It was Active Texas 2020. And thanks to generous support from the Texas Department of State Health Services, the Michael and Susan Dell Center, UT Health, as well as the Physical Activity Alliance, U.S. Physical Activity Alliance, we have undertaken a revision of sorts. For those of you who know, Active Texas 2020 was actually predates the U.S. National Physical Activity Plan, and so we didn't have the benefit of having a pattern to follow. After the U.S. National Physical Activity Plan came online, after the U.S. Physical Activity Plan came online in 2010, and then was revised in 2013 or 14, it was clear that the approach that was taken for the national plan was the way to go, and that's a sector-based approach, allowing for foci in strategies and tactics that can help people and interested parties promote physical activity in those particular sectors. We're extremely fortunate today to have with us the chair of the healthcare sector, who's done a yeoman's job in the last some years in guiding the healthcare sector forward in physical activity promotion. Active Texas 2030 is just like any public health plan, assumes that if you want to, if you know where you need to be and improve population health, you need to have a plan to get there. Texas and West Virginia remain the only two states with standalone physical activity plans, which is a point of pride, certainly for me, but it's also something that we need to articulate out to the other 48 states and territories and others around the country, because I firmly believe in this particular scenario that all health is local. Can have recommendations from national organizations, can have guidance from NIH, CDC, and so forth, but making it relevant to what we do on the ground, we've got to pivot and bring national approaches to the local level, and that's what this series of webinars is for. Is to engage stakeholders at the state and local level who may have an interest in helping join to help promote and improve health through physical activity. There are 10 sectors in the national plan. If you're not familiar with it, the national plan is found on the website www.PAA Move With Us, Physical Activity Alliance Move With Us. And the plans are all laid out there in lovely detail. The overall goals, strategies, and tactics, and objectives, and how to meet those kind of things and so forth. We are focusing today in the healthcare setting. We, on Wednesday, heard from Dan Bornstein, who's the chair of the military sector setting. And in the next 3 weeks or so, the remaining sectors will have their own webinar focus. So please look for promotion on that and join us if you can beyond just today's event. There are some of the dates there. The slides will be made available, but the next one will be July 27th, 1 to 2 p.m. Central Daylight Time, with Dr. Jane Greenberg as the key speaker there. It's my pleasure to introduce Dr. Liz Joy. Liz is the Senior Medical Director for Intermountain Healthcare in Salt Lake City, Utah, and also serves as an adjunct professor at the University of Utah School of Medicine. She has served, as I indicated earlier, as a chair of the Healthcare Sector Standing Committee of the National Physical Activity Plan, and is going to regale us today with a lot of information and hopefully some pearls that people interested in physical activity promotion in this particular setting can take away. She's been a leader in this area in helping develop the physical activity vital sign as a key aspect to patient records, and I'm sure she'll touch on that and other things. So Dr. Joy, welcome. Thank you for being here and giving us an hour of your time on a Friday afternoon. We're looking forward to hearing what you have to say. It's okay for you to share now.
I will go ahead and share my screen.
And while you're doing that, please post questions in the chat box. We'll get to those. There'll be ample time for questions as we go. And there's also an email address to send follow-up questions and the like that I'll show you here in a little bit.
All right, without further ado. So what I'm going to cover today is I'll just start out by describing the healthcare sector strategies to you. We'll review some key strategies, tactics, and objectives with a focus on strategy 1. I'll talk a bit about translating this work into healthcare. So, think global, act local, as Bill was saying. And then, as mentioned, we'll have plenty of time for discussion and Q&A. So the healthcare sector has 4 key strategies. The first being that healthcare systems should increase the priority of physical activity assessment, advice, and promotion. The second, that healthcare systems and professional societies should recognize physical inactivity and insufficient physical activity as treatable and preventable with profound health and cost implications. The third is that healthcare systems should partner with other sectors to promote access to evidence-based physical activity-related services that increase health equity. And lastly, that universities, postgraduate training programs, and professional societies should include basic physical activity education in the training of all healthcare professionals. So when we developed these strategies, I would say that we did so with a very strategic and aspirational approach. People who are part of our healthcare sector are actively working in this space at trying to enhance the role of healthcare, really being a partner with the other sectors, in order to help our patients achieve recommended levels of physical activity. But we didn't want to just include things that we were already doing. We also were pretty aspirational in some respects, and I'll share some of that with you this afternoon. So really, we set those strategies, with respect to what we understood was currently happening within the healthcare sector, and it's not all bad. In fact, there has been some incremental improvement within the healthcare sector when it comes to physical activity promotion. And I'll use the work that Bob Salas has been leading at Kaiser Permanente and that I have been leading at Intermountain Healthcare around implementing the exercise vital sign and the physical activity vital sign into our respective electronic health records and clinical workflow. We also have a great example of the integration of exercise as medicine into a medical school curriculum. This is being led by Dr. Jennifer Trilk at the University of South Carolina, Greenville. And actually, the pictures that you see on the left are all taken from the work that she is leading, working with partners in not only their School of Medicine, but also in the community with the YMCA and with their payer, Prisma Health. So really, if we're going to be successful, we really have to engage so many different components, of healthcare, but also work closely with our partners in the community in order to help patients realize the benefits of regular physical activity on their well-being and their health and chronic disease management. There's also been program development and expansion globally. Walk with a Doc is a great example. I'm not going to really talk about this, but this is a program led by Dr. David Sabgir from Ohio. Now this program is global. And Intermountain, I'm proud to say that Intermountain is a Walk with a Doc partner. And at my clinic, we lead those walks on a regular basis. And it's really phenomenal opportunity, for healthcare providers to get out into the community, share a little bit of information about physical activity and health, and go for a walk with their patient. At my clinic, we do an urban walk with a doc, and we actually walk through the neighborhood wearing our Walk with a Doc t-shirts while we talk about whatever it is of interest to those who are participating. I think the Exercise Medicine program through the American College of Sports Medicine is another example of this. I think there are about just under 30 global EIM centers around the world that Exercise Medicine Vice President Robin Stuhr is coordinating. And again, this has been a phenomenal way for us to further engage healthcare, not only in the United States, but globally. We have seen an increase in physical activity advice within the healthcare space for a variety of populations. You can see here for older adults, those who report receiving physical activity advice from a healthcare provider increased from 43.7% in the early 2000s to more than 50% in 2014. And the percentage of children who are now receiving physical activity advice has increased from about 27% in 2002 to 37.4% in 2010. So obviously there is room for improvement there, but it's not perhaps as dire as some people would have thought. I mean, we are definitely achieving some success and movement, pun intended, in healthcare. So as part of the plan, when it was finalized back in 2017, we defined success as requiring healthcare systems, healthcare providers in practice, and learners to recognize, embrace, and adopt physical activity promotion as a key strategy to improve population health and reduce the overall financial burden of healthcare to the nation and to individuals. And we would achieve this through the broad implementation of the physical activity vital sign, inclusion of physical activity promotion in clinical guidelines, alongside the use of medications or, oftentimes even before medications. I'm fortunate to work in our lifestyle medicine medical fitness centers at Intermountain Healthcare, where we take a lifestyle first, lifestyle always approach when we are doing lifestyle medicine consults and when we're doing providing lifestyle oriented primary care. And I really like that concept. It's super simple. Lifestyle first, lifestyle always. We also define success as partnering across sectors and with community partners and health and fitness professionals, linking patients to the resources necessary to support their regular participation in physical activity. Advance the education of all healthcare professionals, especially primary care providers, to support physical activity assessment and counseling. And then finally, to encourage healthcare providers themselves to be active role models for their patients, their families, and their communities. And this is where Walk with a Doc comes into play. And, we often hear, you practice what you preach. I oftentimes flip that when it comes to talking to my colleagues about physical activity promotion. You preach what you practice. And actually, there are several papers in the peer-reviewed literature, that show that is in fact true. Whether it be physicians, medical students, nurses, if they themselves are more physically active, they are more likely to counsel their patients about the importance of physical activity. All right, so I really kind of struggled a little bit in terms of how to present all this information to you. So Bill is very familiar with this document because I've been sharing it and we've been reviewing it. And strategy one is where we start. And so I really thought we would get into the weeds on strategy one. Unfortunately, we don't have the entire afternoon to talk about all 4 strategies and the tactics and the objectives. So we'll hone in on strategy one, and then time permitting, we can certainly address other strategies that you might be interested in learning more about. So here are some of the strategy again is that healthcare systems should increase the priority of physical activity assessment, advice, and promotion. And so we'll start with the first tactic, which was to use a systems approach, which we defined as an approach that understands how elements of care operate individually and in conjunction with each other to implement, evaluate, and fund interventions that are effective at improving physical activity in children, adolescents, adults, and older adults. And this is what I mean by, starting out by being rather strategic, is that we knew this work was ongoing, but we also want to be able to demonstrate it, at scale. And so we included by 2020 at least 2 nationally recognized healthcare systems that in combination serve at least 10 million individuals will have developed and disseminated approaches for team-based care to address physical activity and sedentary behavior in the healthcare setting. And as I was reviewing this and reporting back to Bill and the other leaders in the National Physical Activity Plan Board, I would indicated that we have achieved this. This has been done at Kaiser Permanente, again, under the leadership of Bob Salas, as well as at Intermountain Healthcare. And I'll share some examples of how this is true. And secondly, that at least 2 nationally recognized healthcare systems that, again, in combination serve at least 10 million individuals will have implemented and evaluated evidence-based behavior change strategies that address physical activity and sedentary behavior in healthcare settings. So I'd really like to take just a moment and show you how we determined that this objective was achieved. So what you see on the left-hand side of your screen are simply 2 papers that have come out of Kaiser Permanente. At the top is a paper that was led by Debbie Young, who is one of the researchers that works closely with Dr. Salas. They were able to look at the association between physical activity and cardiometabolic risk factors within their healthcare system. And again, it's by virtue of the fact that they've integrated the exercise vital sign into their electronic health record and they're utilizing it in clinical practice. A medical assistant is actually collecting the physical activity vital sign at the point of care, documenting it in the electronic health record. It has really good product placement, so it can be visualized by the provider as part of their clinical workflow and then integrated into the visit and can actually be a part, of promoting health and preventing and managing disease. And so it's not surprisingly that, given the wealth of data, that this vital sign actually provides, Dr. Salas led a sentinel paper looking at the relationship between physical inactivity and severe COVID-19 outcomes. And I suspect many, if not most, or maybe all of you are aware of this. This was published in the British Journal of Sports Medicine, certainly received a great deal of media attention because they were able to demonstrate that people who were physically inactive were more likely to have more severe COVID-19 outcomes. They were more likely to be hospitalized, to require ICU treatment, and to die compared to people who are more physically active. And again, this work we're able to do this work and to use this kind of work to inform clinical practice, because they have successfully developed and implemented the exercise vital sign into clinical practice. So speaking of implementing into clinical practice, easy to say, turns out hard to do. I mean, simply plopping, a physical activity vital sign or exercise vital sign into the electronic health record, is not going to change, knowledge and practice, of complex, highly matrixed healthcare systems. And so, one of the things that Intermountain Healthcare, I think, is most known for is their implementation science and their commitment to implementation science, and realizing that there's like this whole waterfall. I should have included a slide of this, but I'm sure, for so many of the researchers on the call, you're familiar with this, that, we can develop something, then we have to figure out how to disseminate it and make sure we get the information, to the right people. Then those people need to decide whether or not they want to adopt it. Is it important enough to actually do it when there's so many other things that we have to be doing in healthcare? And then we have to make it simple enough or provide sufficient structure and support that can be implemented with fidelity. Because we all know that if you have an intervention, but it's too complex to implement with fidelity, like what's the point? And then we have to have built into it, a way to evaluate it so that we have, continuous learning. And that continuous improvement is, of course, essential to delivering healthcare. So Intermountain creates care process models, and I have been a part of both of these care process models. The top one is our lifestyle and weight management care process model for adults, and the bottom one is our lifestyle and weight management for children and adolescents. And I'll just add, my one of my major contributions to this was that these care process models used to be called weight management for adults and weight management for children and adolescents. And when I joined Intermountain 11 years ago, I was like, whoa, 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 whoa. We need to really be talking about lifestyle behaviors. And, that is the foundation, for health and certainly when it comes to achieving and maintaining a healthy weight. So we really, again, in this setting, did a kind of a physical activity first approach. And so we really implemented our work around the adult physical activity vital sign. And it also prompted us to create a child and adolescent, what we call the PEDS PAVs. And I didn't include anything on the PEDS PAVs. I don't know, maybe Bill, you'll invite me back sometime and I can talk about our work solely in the physical activity vital sign around adults and pediatrics. I didn't include any of that data today. But we've had a great deal of success. It's been very well accepted by our pediatricians. And we're learning a great deal about physical activity behaviors amongst children and adolescents. In terms of evidence-based behavior change, I wanted to share this with you. This is really exciting to me. So we wanted to create kind of a behavior change framework that would help to inform any behavior change that we wanted to tackle with our patients, whether it was around physical activity or healthy eating or sleep behaviors, substance use behaviors, medication adherence. And in creating this, we really looked to the evidence and leaders in behavior change. Obviously, taking into account Prochaska's stages of change, the trans-theoretical model, the work of B.J. Fogg and BMAT, and his colleague at Stanford, Dr. Carol Dweck, and mindset. And I think this diagram is a little complicated, so let me walk you through it a little bit. And it's really saying that we're going to try and understand the patient's motivations for change, the abilities that they bring to the table around change. How do we use prompts? B.J. Fogg refers to them as triggers, but how do we use prompts to help remind people that they're going to continue with their change efforts? But we recognize that, change does not take place in a vacuum. It happens in the context of your relationships, some of which may be positive, some not so positive. Your environment, your home environment, your work environment, and your mindset. And all of those things, are what support taking action, making small steps over time. So you build in success, and that leads ultimately to the desired outcome. And so, I oftentimes think of it in much more simply, not so much the picture, but, what are your motivations, your abilities? How do we use prompts? And we think about it in the context of relationships, environment, and mindset. Again, helping people to take small steps to achieve the desired outcome. So, for example, the patient that I saw the other day, who came in to see me with, desired weight loss, we really started by setting a goal of 5 to 10% weight loss from baseline, even though I think she wants to lose 50 to 100 pounds. But let's try and have some success and then build on it from there. And so this all looks very, very fancy, but I'm going to tell you, when I'm talking to my patients, I oftentimes pull a napkin out of the towel dispenser. I write down these things: motivations, abilities, prompts, relationships, environment, and mindset. And then we go through it together. So, in the case of this example, the motivation was to run a half marathon and to lose weight. And, when asked, what are the abilities that you bring, to this goal? Well, she ran track in high school. She was a pretty good runner, but, stopped running in college and then, got married and had kids and really never got back into it. We talked about what could be some prompts, what would help her kind of stay on track with this goal. And we talked about maybe signing up for a running club, and she was thinking about using an app. She had an Apple Watch and she has an iPhone, so she figured that would be helpful. In terms of supportive relationships, she's going to do it with her best friend. And the two of them together are going to train together when they can, try and do a long run on the weekends, and that would help her have some accountability, and it would be more fun to do it with a friend. In terms of environment, she realized that, if she went home, after work, there was no way she was putting on her running clothes and going out for a run. So it was best to kind of train immediately after work and not go home, where she's more likely to get sucked into homework and making dinner and, just the running down the day's events. So training immediately after work was going to be her strategy, along with a weekend run with her friend. And then from a mindset perspective, in mindset's this idea of, do you have a growth oriented mindset, meaning that you see the potential for change in you? Or is your mindset more fixed and negative and you're like, yeah, well, I've been trying this forever, nothing's changed, so why bother? It's too hard, my family demands are too high. So she said that she was going to connect with a friend and her training partners when her mindset was more negative. So this is just an example of us driving, the use of an evidence-informed behavior change framework, that would support our efforts in promoting physical activity in the healthcare system. All right, so then moving down here to the third bullet under objectives, we said that by 2020, at least one high-quality pilot program will utilize a team-based care model to increase physical activity assessment, counseling, and referral in ambulatory care settings. And, there are actually, several examples of this. And the two that I chose for inclusion in our plan outcomes was one by, again, Dr. Trilk. And this is published a couple of years ago in Preventive Medicine Reports on the design and implementation of a clinic to community physical activity health promotion model for healthcare providers. And it really encouraged you to take a look at this for kind of the how-tos in a healthcare system. She's obviously an academic healthcare system that has partnered with the primary care programs, primary care educational programs, as well as community partners in order to deliver physical activity resources to patients. And then I also am highlighting the work that Dr. Sarah Linke has led at University of California, San Diego, under a K Award. And this is the study protocol that is currently in place. This is some ongoing work that she is leading on integrating the exercises medicine model into primary care workflow, and really starting with a physical activity vital sign in kind of an expert model. So, that is screening with the PAVs, brief intervention, so a conversation about the relevance of physical activity in a person's health and wellness. And then the RT is referral to treatment. And with physical activity, it's not so much treatment as it is resources, although for some people it may be treatment because, in order for them to really engage in a regular physical activity program, maybe because of a musculoskeletal or neuromuscular problem, they actually need to see a physical therapist first. So treatment might, in fact, be the first route before they transition from physical therapy to physical fitness. But nonetheless, it's really the exercise as medicine model is this SBIRT approach of screening, brief intervention, and referral to treatment. And of note, for the physicians who are on the call today, that's a very familiar approach. We use that SBIRT approach with lots of other conditions, and notably in substance use disorder. So, when we're trying to help people achieve meaningful behavior change, we want to be able to do it not just once, but repeatedly. As we see these individuals over time, and using that SBIRT approach can help you really kind of structure that conversation in a way that, makes sense, makes you remember it, but it also then is become part of a consistent message, to that patient. I think sometimes, we don't get, a very effective or efficient delivery of our information, and that can lead to patient confusion. All right, so this is moving on to the next tactic, and this is around making physical activity a patient vital sign that all healthcare providers assess and discuss with their patients. And the objective was by 2020 to nationally recognized healthcare systems, blah, 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 will have developed and standardized and validated an approach using a self-report instrument to assess and document aerobic physical activity in children, adolescents, adults, and older adults. And again, lots of examples here of where this has occurred, both at Kaiser Permanente and Intermountain Healthcare. Again, as we were building the plan, we knew that this was in progress. And, but we also knew that, by sharing it, by doing it and sharing it, hopefully it would motivate and stimulate, other healthcare systems, around the country to do exactly the same. All right, so one of the objectives with this particular tactic is that by 2020, 5 healthcare systems will have implemented a physical activity vital sign in the electronic health record and clinical workflow. And we have, more than achieved this. I think if we had set entry, target, and stretch goals, I could say that we achieved stretch on this one. These are only the ones I know about, having reached out to colleagues across the country and working closely with Robin Stewart, Exercises Medicine. But Kaiser and Intermountain have had, the vital sign for quite some time. And adding to that is the University of Michigan under the leadership of Carrie Dene, University of Washington under Cindy Lin, the work that Jennifer Trilk is leading at Greenville. And then more recently, one hospital and another healthcare system in Texas have actually implemented a physical activity vital sign into the electronic health record and clinical workflow. So very exciting. And like I said, I know there are more, but those are at least some, and we definitely exceeded the 5 that we had committed to. By 2025, at least one nationally recognized healthcare system will pilot, test, clinical assessment for muscle strength training and sedentary behavior in ambulatory care. Now you can see there is nothing there, but I am going to show you what we're doing at Intermountain, and I don't have any data to share around this, so we haven't indicated that we've even achieved partial achievement here. But we do have on the left, this is our Live Well Center assessment. This is an assessment that is integrated into our Cerner electronic health record, and it is performed by our exercise physiologists. We have 5 medical fitness centers. They're scattered across the state from St. George, Utah, which is in the southwest corner of the state, all the way up to Ogden Live Well Center. which is in kind of north central Utah. My Livable Center is in Salt Lake. Then there's one in Park City. And then the fifth one is in Provo, Utah, home of BYU. But you can see I circled in red grip strength. And so as part of our Live Well Center assessment, patients do undergo grip strength testing at entry and then at 6 months into the program if they are involved in our medical fitness program. And our medical fitness program includes both personal training, one-on-one, group personal training, which is oftentimes couples who are meeting with an exercise physiologist. And then we have group exercise classes at various levels. It starts with chair-based exercise, for people who may have, are quite frail or have balance issues, and then really moves up to, fairly vigorous group exercise classes. And additionally, we have a Pedaling for Parkinson's program, and we have some spin classes, and we have yoga, and it's kind of a typical medical fitness center. But all the patients who come into our medical fitness center have their grip strength tested at entry and 6 months into the program. So, eventually we will have some objective data around, how does grip strength actually improve when people participate in a medical fitness program. And I continue to advocate for the addition of grip strength as part of our Medicare annual wellness visit, because I'm sure, many of you know that, it is more predictive, of premature mortality than blood pressure, and yet we certainly measure blood pressure in everybody. And doing, performing a grip strength test is pretty easy to do. And we have normative data. So I'm really hoping that we can get there in the not too distant future. I'm going to go back here just to share some of the other tactics or objectives here. One was that by 2020, 75% of physicians will report providing specific guidance to increase physical activity, often or always, according to this surveillance system. But unfortunately, since we developed these objectives, that surveillance system no longer exists. And in talking with colleagues and, at the CDC, there is no plan to resume this surveillance system, given some funding limitations. But we have been speaking with others about, other forms of surveillance that might allow us to reach, to get this type of data. And then lastly, by 2020, 50% of patients report being advised by their physician to engage in regular physical activity according to the National Health Interview Survey. Now, this one definitely happens very regularly. The last time it happened was in 2020. And at the time I submitted these to Bill and the NPAP board, that was in, I think, probably sometime in June, May or June. And the results still are not out yet. It says pending on the website. So looking forward to seeing those. I anticipate they will be out soon, and we'll be able to see whether or not we have achieved this. All right, so oh my gosh, this is work I have been working on for so long. So much good stuff going on in this space, but this is someplace where I would just have to say I have utterly failed. So we have a tactic to develop physical activity as a healthcare quality measure for adult patients age 18 to 64. And then expand utilization of the existing measures for children, adolescents, and older adults. Okay, so the second half of that objective we have, by and large, achieved. But I have spent probably a decade trying to get an adult physical activity HEDIS measure with absolutely no success whatsoever. And I'm really hoping that with the Physical Activity Alliance that Bill and I are a part of, that we'll have some more success with additional stakeholders on board and some other work that we're doing from a technological perspective. But we have not yet achieved a HEDIS quality measure for physical activity and adults. And nor have we really been able to say that two value-based healthcare systems, are using physical activity assessment and counseling as a quality incentive. We did do that briefly at Intermountain. We had a great deal of success in a small pilot with our sports medicine physicians, some family docs, internists, and OBGYNs. And in fact, I should have included this picture. We incentivized our sports medicine physicians that, in order for them to qualify for the quality benefit, or the quality incentive, which was a sizable dollar amount, they had to be able to document, self-reported physical activity in the electronic health record in 80% of their patient visits. That's a lot, 80% of their patient visits. And half of those individuals, they had to have documented advice to start, increase, maintain, or modify physical activity. And it wasn't an or, it was an and. So in order to meet the measure and to qualify for the incentive, 80% had to have documented physical activity, and 50% of those, or 40% of the total, had to have documented advice to start, increase, maintain, or modify. And you know what? They all made it, 100% of them. And we had the incentive in place for 4 years, and it was a 4-figure incentive. I'll just add that. And then the incentive went away. And we all thought that, of course, the numbers would tank, right? They were no longer getting the money. But it turns out, when I looked at that 2 or 3 years later, they were still sitting at about 80%. So with 4 years, they actually developed, practice and process and culture around this. And they saw how it was of value to their practice. And we really didn't see it fall off. So, if we're going to have pay for performance measures, I guess it doesn't matter what we're talking about. But at least I can say in the physical activity space, 4 years of pay for performance paid off. So the next objective was looking at were we successful at expanding physical activity assessment and counseling for children, adolescents, and older adults. And you can see we had definitely achieved this for children and adolescents. We set the goal at 60%. And looking at NCQA HEDIS data, because we do have a physical activity HEDIS measure for children and adolescents. For commercial HMO, we're at 63%, a little lower for Medicaid and PPO, or preferred provider organizations, and then for Medicaid HMO at about 64%. So super psyched to see that having a HEDIS measure for physical activity has resulted in an improvement in physical activity counseling for kids. When it comes to older adults, I'd say we nearly achieved based on the data from NCQA. And I think a real driver for this is because it's a STARS measure. That means that it influences our payment from Medicare. And so we again set the bar at 60%. And you can see that, for PA discussion, I'll jump down to Medicare PPO, we're at about 58%. And I guess I'm not terribly surprised around physical activity advice, but it's a little bit lower. So some room for improvement there, but nonetheless, heading in the right direction. All right, next with strategy 1, our next tactic was to develop, implement, and evaluate strategies to integrate into healthcare settings objective measures of physical activity that are derived from wearable devices and smartphone applications. And you can see that I have bumped all of these to 2025 because, we just do not have widespread utilization of wearable data integrated into healthcare. There's a lot of reasons for that that I just don't have time to go into, most of which has to do with, a lot of concerns within healthcare about our data being hacked and held hostage. And, we cannot create any doors, into patient data. Huge fines, if, we get hacked because somehow or another, we can't safely integrate this data and still protect patient privacy. So, I think this is coming for sure. I know that various wearable companies are working with some of our electronic health record vendors, but it is not happening at scale. And then next we have encouraging healthcare professionals to be role models for active lifestyles for patients. we had an objective that, again, 2 leading healthcare systems will have expanded, developed, and disseminated programs to their healthcare providers. And I said, I think we've partially achieved this. And as an example of this, Intermountain's our Live Well program, or how to create a culture of movement at work, was identified by the Health Enhancement Research Organization, or HERO, as an exemplar when it comes to promoting an active work environment. So kind of coming here to the end, I thought I would spend a little bit of time about how do you translate this work into healthcare or into clinical practice. And first and foremost, you need a clinical champion. It really does take a squeaky wheel. And I guess, I'll put myself in that category. One of the reasons why I actually went from the University of Utah to Intermountain Healthcare was that Intermountain is an integrated healthcare delivery system. And that means that we incentivize keeping people healthy, rather than just trying to manage expensive disease. And so when I went to Intermountain, I was intent on implementing the physical activity vital sign, which we'd started to develop at the University of Utah within Intermountain. And the way I did that was hooking my wagon to a leader champion. And I identified one of our medical group leaders who is a physical activity fanatic, just like me. And, with his degree of influence, the two of us were able to develop it, prioritize it, integrate it into the electronic health record, and implement it across our medical group. So I think those are 2 key elements when it comes to translating strategy 1 into healthcare and clinical practice. But you also need to have a compelling why. And I'll tell you that the compelling why for us was that the physical activity for older adults was a HEDIS quality measure, and it drives reimbursement from Medicare. And here's where we are right now. You can look at, I'm probably not supposed to show this, so don't repeat it. But these are some of our HEDIS measures going back to 2018 for monitoring physical activity. And you can see, going out to 2022 on the far right, we are at 5-star. That means we've maximized that star. It only goes as high as 5, and we're doing a really good job when it comes to assessing and promoting physical activity in older adults. So the next really compelling why was cost savings. And this is some work that's been done by Dr. Trevor Ball and myself, presented at ACSM and in preparation for publication. But we looked at the relationship between healthcare utilization and cost by self-reported physical activity level. And you can see that, there's we approach, a 2-to-1 relationship here between, inactivity and sufficient activity when it comes to visits and cost. So again, more than 2-to-1 when you look at inpatient visits, 2-to-1 for emergency room visits, and nearly 2-to-1 when we look at total hospital costs. So not surprisingly, we're now able to demonstrate that our most physically active individuals, and by that we're saying they're sufficiently active and doing at least 150 minutes per week of MBPA, that they have decreased utilization and lower cost. Another thing that is super, super important in healthcare right now, and again, drives reimbursement, has to do with this idea about likelihood to recommend and frankly, brand loyalty. There's lots of choice in healthcare, and you want people to choose you, choose me, and I read this article the other day, and it was the CVS Healthcare Survey. This is a survey they do every year. It's huge. They get like tens and tens of thousands of people to respond to it. And these are some of the results of that survey from this year. That 83% said they want their primary care physician to know about their family medical history, genetics, and inherited lifestyle habits. 83% want their doctors to understand lifestyle habits and their impact on health. 80% want them to understand health goals. 70% want their providers to understand supportive relationships. And I just, and it goes on to say that 80% of respondents also want to focus on preventive primary care. So I think the time is now, for us to really kind of take that holistic lifestyle first, lifestyle always approach in caring for patients. It starts with physical activity and includes healthy eating, restorative sleep, stress management, the avoidance of unhealthy substance use behavior, the environmental health and social connectedness. We used to say there were 6 pillars of lifestyle medicine. I really think there are 7. And then I think another thing that really helped us a great deal in terms of being successful at this at Intermountain is our mission. And when something like this is mission critical, ours of which is helping people live the healthiest lives possible, it makes it hard for people to say no to me. I'm like, really? Physical activity assessment and promotion is not helping people live the healthiest lives possible? And of course, our CEO is an 8-time Ironman triathlete. That helps a bit too. And then lastly, I think it's really around leveraging the success of others. There's a lot of water under the dam here. We've done a lot of work. And, I'm here today because Bill asked me to come, and I've given this talk in various forms to healthcare systems around the country, academic healthcare systems, payers, integrated delivery systems, you name it. Because for me, it's a bit of the gospel. And I'm really happy to have had the opportunity to share some of our work with all of you. We can certainly revisit, any of these other strategies if you like. And I'm also happy to just answer your questions. So, Bill, I'll turn it over to you.
Liz, thank you very, very much for that comprehensive overview of this sector strategy, particularly the first strategy. It's just, our friend Greg Heath, many of you may know, University of Tennessee, Chattanooga, invariably starts one of his lectures with a cartoon of a wolf howling at the moon, and he poses the question: with physical activity and public health, are we howling at the moon? Seeing the results and the progress in the healthcare sector, meeting goals, setting new goals, continuing to not take no for an answer in a lot of these areas is so inspirational to me, certainly, and I hope it will be to everyone who's been on the call. Just seeing that things that weren't there 10 years ago, because of the National Physical Activity Plan, we now have measurable progress in a lot of these key areas. Liz, we've got about 8 minutes. Would you mind unsharing, and I will share because we've got a couple of questions I'd like to pose. If anyone in the audience has questions, we'll have some time for verbally talking about them, but you can also post them in the chat box. Liz, one of the things that the reason why this seminar series is here is to engage stakeholders in each of the particular sectors. And the progress at the national level in California and in Utah as well. It was nice to see Memorial Hermann Healthcare out of Houston being one of the key groups that's adopted the physical activity vital sign. But what would you say as we work towards this plan for 2030? What would you say the lowest hanging fruit in your experience would be that we might be able to engage community leaders, clinicians, healthcare executives, even nurses, nurse practitioners, and the like, who might be motivated to become one of those leaders that you were talking about?
Oh my goodness, that's a loaded question, Bill. Lots. I'm like reading through these questions you have listed here, and let me just start by saying that in regard to kind of state and local public health, I think a couple of areas. So one is I think a lot of state health departments and probably pass through money to the locals, had the clinical community linkages grants from the CDC. It was pretty big funding, a few years back. I definitely participated in that from a clinical perspective, and also chaired our work in physical activity in healthcare. And that was an opportunity for us to, better understand each other in terms of, what we were doing, where were the resources, how do we support? It's one thing when you've got Intermountain Healthcare, right? We've got 70,000 employees and, we're in, I don't know, 7 states now, I think. It's a really big place, but how do we help smaller practices be successful with that? So that clinical community linkages work with the state and local health departments, I think did have a positive impact, on particularly smaller practices throughout our state. I think another area that is, certainly is very inclusive of physical activity is the diabetes prevention program. And, it is the world's best evidence lifestyle change program. Again, states are funded by the CDC, and that funding is often distributed through local health departments in order to provide the 1-year DPP program to local residents. And I think that's another example of where we can, work within an established program with an incredibly strong evidence base and frankly enhance the physical activity component of that. I presented on that at ACSM this past year, how to optimize physical activity in the DPP. There's work to be done there. I'm talking to some of the virtual providers, to Chris Holliday at the CDC. So, that's another place where we should, those of us who are in the physical activity world should be partnering with our DPP deliverers, to improve the physical activity component of that curriculum. I mean, oh my gosh, 1 in 3 adults in the United States has prediabetes. 1 in 3. I mean, throw a ball at a crowd, you're going to probably hit a couple people with prediabetes. So I think that that's a place where we can have some quick wins.
Great. And then I will say I posted an email address there. Anyone on the call who's interested in sharing some local successes in this particular sector, as we put the plan together, I'd love to consider featuring those successes as part of the plan to give people an idea about how to do these, following up on what Liz was saying earlier as well. So please don't hesitate to use that email address. Among participants, are there barriers that you'd like Dr. Joy to help you address? Maybe if you've come across or you've been thinking about this, is there anyone here who'd like to kind of get some expert input in terms of overcoming those barriers that might help achieve these the strategies and tactics locally here for the healthcare sector? I see that Liz has also put her email address in the text box. One thing.
Yeah,
Go
our
ahead,
time's
sorry.
short. So certainly if people have more detailed questions, want to get into the weeds, you can email me and ask a question, or, we can set up a call offline, but, happy to provide assistance if it would be helpful.
One thing that's always been in the healthcare sector is the money, right? Is the economics around it, the costs, and you presented some intriguing data right at the end about the economics. Is that enough to sway executives' minds, you think?
Oh my gosh. Well, let me tell you how it swayed executive minds at Intermountain. So we presented that data to our payer. So we're an integrated delivery system. Our healthcare insurance carrier is called Select Health. They insure well over 1 million lives. And when they saw that data, they created something that we actually implemented this year, that for our Select Health Medicare Advantage program, that those members have no cost access to our LiveWell centers, both in person and virtually, for lifestyle medicine consults, nutrition consults, exercise physiology consults, personalized exercise prescription, and personal training and group exercise classes. No cost.
Wow.
They believe that if we get people more active, those healthcare costs will come down. And so we just found out yesterday we've been approved for a 2nd year, and the program has been wildly successful.
That may be the single most important lever to pull down on the use on the fulcrum to get that get some of those things embedded in the program. Well, Dr. Joy, Liz, thank you very, very much. I want to be respectful of everyone's time. It is 2:00 Central Time, and 3:00 Central Time. I do wish that I do hope that everyone who's joined us has gotten a good overview of this particular strategy in the healthcare sector. And again, please, with any questions, you can email Dr. Joy directly or activetexas2030@uth.tmc.edu. I would like to recognize the Michael and Susan Dell Center for Healthy Living, the UT School of Public Health, the Texas State Department of Health Services, and the U.S. Physical Activity Alliance for the support in pulling these things together. And I hope everyone has a great afternoon. Thanks again.
Bye.